Then maybe we can get started while we wait for others to join. So welcome all to the AAD 2023 Congress Highlights on Psoriatic Diseases. This is the second edition of this GRAPPA Congress Highlights that we're hosting with Fabian Proft. And we want to welcome all of you to today's event. So the overarching goal of this event is for us to have an interdisciplinary exchange between dermatologists, rheumatologists, and other practicing clinicians and researchers interested in psoriatic disease about the most recent evidence that is being presented at the major conferences dedicated to dermatology and rheumatology with a focus on psoriatic diseases. So we previously had another session focused on the abstracts, the most relevant abstracts presented at ACR in 2022. And this year we're focusing on AAD 2023. And the hope is that we can engage not only GRAPPA members, but other people who are interested in this field, and also invite you to become GRAPPA members if you wish after this opportunity. And the way this will go is we will have three white GRAPPians who are three dermatologists who are affiliated to GRAPPA. They will be presenting the abstracts that they have selected together with three senior GRAPPA members who have supervised them during this process. In the following slides, Fabian will be explaining better the outline for the session. If we move on to the next slide. I am Lourdes Perechada. I am a dermatologist. I work as a clinical investigator at the Brigham and Women's Hospital in Boston. I'm an instructor in dermatology for Harvard Medical School, and I work very close with my dear friend and mentor, Dr. Joseph Merola. And Fabian, I'll let you introduce yourself.
Yes, thank you, Lourdes. Welcome, everyone, also from my side. It's a real pleasure to see so many of you and the interest that you bring to the table here for the GRAPPA Virtual Congress Highlights, and especially for me as a rheumatologist to hear the highly relevant abstracts that were presented just recently at the AAD conference in New Orleans. I'm excited to hear about them, and especially I also wanted to engage all of you here in the audience, because I think it can be a very interactive discussion, and I'm really much looking forward to the presentations that will be given by the young GRAPPians. And I can only encourage everyone, please write your questions and answer questions into the chat function, and we also have a panel discussion at the end. So I'm really much looking forward to the presentations, but especially also on the discussion on the different abstracts, and also having some of the authors here in the panel. I think this is a great opportunity for all of us to engage in this. And yeah, it's exciting to, after we were at the hearing about the Congress highlights from ACR, to have now the first dermatological edition. And I think without any further ado, we should get started. And we will start with the basic science highlights, and they are presented by Gemra. And I'm really much looking forward to your presentation. So maybe you can just start from here.
Hey, hello everyone. Good morning, everybody. Thank you for having me today. It's a real pleasure to meet with you. My name is Cemre Büşra Türk, and I am originally from Turkey, and I'm a dermatologist in there. But currently, I'm working as a postdoctoral research fellow at MGH in Boston with Dr. Rox Anderson and Dr. Yakir Levine. Today, I will briefly cover the basic science part of this event. And to prepare this presentation, I work with Dr. Wilson Leo, and he helped me a lot. So we can move forward. These are our disclosures, and none of them directly related with today's talk. And here you may see the abstracts that we were going to briefly cover, and we may move forward. Okay, let's start with the first one. This study is about differentiation of therapeutic monoclonal antibodies targeting IL-23 for the treatment of psoriatic disease. We can move. For starting, I would love to show you this graphic for a quick orientation. As you may know, today we have different targets to reduce the inflammation to treat patients with psoriasis. This study is specifically about IL-23 inhibitors, which are guselkumab, tildrakizumab, and risankizumab. Okay. However, even they target the same point at that graphic, guselkumab, tildrakizumab, and risankizumab have different molecular attributes and different therapeutic profiles. We can move. In the light of this introduction, the authors of this study aim to explore potential mechanisms that underpin the difference in the therapeutic profiles of IL-23 inhibitors. They assessed in vitro binding affinity and potency of IL-23 inhibition using a cell-based assay, and they were assessing in vitro Fc binding to Fc gamma receptors on human cells and functional effects. To assess these properties, they use different in vitro assessment tools such as surface plasmon resonance, kinetic exclusion assay, STAT3 phosphorylation assays, and they were using HTRV assays, flow cytometry, and assessment of stakin secretion. We can go. Let's take a look at their results. According to their results, guselkumab and risankizumab bind to human IL-23 with similar kinetics and affinity, and they have higher affinities than tildrakizumab. Here you may follow the binding kinetics with the green line for guselkumab, pink line presents risankizumab, and the yellow one for tildrakizumab. And the Kp values were around 3 for guselkumab and risankizumab, but Kp was around 201 for tildrakizumab. We can move. Regarding the IC50 values and inhibition potency of IL-23 induced proximal signaling, guselkumab and risankizumab were similar, but they have higher potencies than tildrakizumab. Here you may follow guselkumab and risankizumab with the green and pink line, and they have similar pattern as you may see. However, tildrakizumab, the yellow line, has 7 to 10-fold lower potency. Regarding the affinity of binding Fc gamma receptors, guselkumab and tildrakizumab show the strongest binding to cells transfected with CD64, as indicated by a decrease in HTRV for control antibody binding, while risankizumab show minimal binding to Fc gamma receptors. You may follow the risankizumab as a pink line here. Yes. We can move. And these binding affinities to human inflammatory monocytes were dose-dependent in an Fc-dependent manner for guselkumab and tildrakizumab. However, as we talked previous slide, risankizumab did not bind to interferon gamma prime CD14 monocytes. You may realize guselkumab and tildrakizumab graphics are changing in a dose-dependent manner, but risankizumab stays same. And the authors evaluated the relationship between guselkumab and tildrakizumab binding to interferon gamma prime CD14 monocytes and Fc gamma receptors expression, and they found that binding of guselkumab and tildrakizumab to interferon gamma prime monocytes correlates with the level of CD64 expression, but not CD32 or CD16. You may be aware of CD64 with the green box here. And yes, you may realize the positive correlation in between CD64 and guselkumab and tildrakizumab. Okay, so for conclusion, okay, they have same target, but they have also different molecular and therapeutic properties. Especially guselkumab shines at this point because it binds and neutralizes IL-23 with a high affinity, and it can bind to CD64 on primary human inflammatory monocytes in a dose-dependent manner, and it does not induce stakin production. We may go. And we know previous studies have shown that CD64 mononuclear phagocytes are enriched in psoriatic skin and serve as a predominant source of IL-23. And IL-23 blockade with guselkumab reduced tissue-resident memory T cells in psoriatic lesions, consistent with maintenance of clinical response. So we may comment at this point, guselkumab's presence may be enriched within the inflamed tissue microenvironment by binding CD64, thus neutralizing IL-23 at its cellular source and leading to durable response and potentially observed therapeutic differences within IL-23 P19 inhibitor class. And we can, if it's okay, I would love to move forward with the new study. Okay. This study is about pharmacoepigenomic effects on TNF inhibitor and phototherapy treatments in moderate to severe psoriasis. As you know, moderate to severe psoriasis is difficult to treat and maintain the well-being, and therapeutic response varies widely and is hard to predict, challenging to study on its long-term course, and due to the chronic and fluctuating course, it's, as I said, it's hard to predict. We can, yes, epigenetic clock, please go back. Yeah, epigenetic clock is the correlation of DNA methylation and chronological age, and it is an effective predictor of various disease and mortalities. And this study is specifically about epigenetic age acceleration, which we can call it as a EAA. When DNA methylation is bigger than chronological age, we can call it EAA, and it is implicated in many complex disease states and poor prognosis. So the main objective of the authors to assess the role of epigenetic aging in psoriasis treatment, and they were trying to define epigenetic age acceleration in the context of inflammatory skin disease and to understand the impact of psoriasis treatments and epigenomic landscape. And they were trying to appreciate the viability of epigenetic clocks as avenues for future biomarker studies of psoriasis pathophysiology. To plan this work, they planned this work as a case control study on 2 different cohorts. We'll see in a minute. The data set that they were using is alumni 450K microarray data, which is a publicly available data set. And they were using the methyl-CloakR package to estimate the EAA. First cohort was chosen among adult population with moderate to severe psoriasis who treated with TNF inhibitors. And the treatment responses represents as 2 groups. Excellent responders who got PASI 19 at 3 and 9 months, and partial responders who got PASI 75 at 3 and 6 months. And unfortunately, non-responders were not included in this study. And after choose the patients, authors assessed their peripheral blood DNA methylation. For second cohort, they were choosing the patients among adult population with moderate to severe psoriasis who treated with narrow band UVB phototherapy, and they also included untreated healthy controls to this cohort, and they separated the time as 3 different points. They were pre-UV, which is before any UV therapy, mid-UV, which is following 1 month of the treatment, and post-UV, which means following 2 and 3 months of the treatment. And responses were evaluated by researchers as excellent, good, and unsatisfactory. And they were assessing epidermal skin DNA methylation at this cohort group. So if we take a look at the results, we can realize the first results for cohort 1, and reduced EAA has shown in excellent versus partial responders in all anti-TNF users, and same trend among was observed in etanercept treated patients. However, the data not shown on the slides, on the poster. And we can go. EAA across anti-TNF groups among excellent responders was like etanercept-treated patients have lowest EAA, and then adalimumab, and then infliximab-treated patients have the highest EAA. We can move forward. Regarding narrowband UVB treatment and epigenetic age acceleration, phototherapy was associated with epigenetic and biological age acceleration, and treatments diverged from healthy control, and more significant effects among excellent responders was observed. However, data not shown on the posters, and we may move forward. And phototherapy was associated with increased telomere length. Treatment converged toward healthy control, and similar trend among excellent responders was shown. However, data not shown on the posters. We can move forward. As a conclusion, excellent response to anti-TNF treatments is associated with reduced epigenetic age acceleration. Narrowband UVB therapy induced differential epigenetic aging effects indicative of treatment efficacy and possible side effects. And pharmacoepigenomic effect of psoriasis treatment is measurable through epigenetic cloak analysis and is linked to treatment response. And lastly, epigenetic cloaks may serve as viable tools in the clinical assessment and personalized treatment of psoriasis. We can move forward. Before finishing my words, you know, I am from Turkey, and we in Istanbul we have Bosporus, we have bridge which links Asia and Europe. I believe GRAPPA doing same thing. It binds Europe and US. It binds clinicians and researchers, binds dermatologists and rheumatologists, and also senior GRAPPA members and young GRAPPians, and you know, gives us an amazing opportunity to work with legendary names. I want to give my thanks this group, and especially Dr. Liao, to help me a lot. Thank you for listening to me.
That was wonderful. Thank you so much, Emre. So does anybody have any pressing question on the abstracts that we're just presenting? I want to give an opportunity to the audience if you want to raise a question, and in the meantime, if not, I'll bring one about the first study. So it was very interesting to see how the different agents have these different molecular properties and how those translate. I was thinking how this will translate later into clinical practice. So my question is mostly for the dermatologists in the panel. Do you see differences clinically among these three agents when you are treating your patients with psoriasis? And we have also Fabian and Joe as rheumatologists here who can also speak about their impression from a rheumatologic perspective regarding PSA, that we know that IL-23s are not as effective as other agents. So whoever wants to take the floor.
So Lourdes, I was, it's a great comment / question. I was going to actually raise a similar question. I was going to maybe make a comment, and then if maybe I was hoping Wilson might make a comment about this, because specifically, it's interesting to me. You know, I like this concept that there are some differential potential functions because of molecular structure of the three IL-23s that were mentioned in that particular poster. That's been sort of a hot topic, and the question of whether it may have impact, in particular, you know, in the rheumatology space, in different domains, different compartments, axial, you know, et cetera. I guess one of the questions I would have is, clinically, to your point, you know, we see high efficacy from these drugs in the skin. I don't think that there are dramatic, deep differences in efficacy between those agents from a skin or joint perspective, and I'm namely speaking between the risankizumab and guselkumab molecules in the study, including long-term impact, you know, and what we would call, you know, if we look at, for example, the efficacy that remains after withdrawal of drug, it's quite long. And we've talked about how that may have impact on what, you know, Jim Kruger's called the molecular scar, on, you know, tissue resident memory T cells, et cetera. And so I would ask Wilson, because I you know, to me, I see more similarly than not in terms of clinical efficacy. Although that finding is fascinating, is there some reason to think biologically that there's a difference there, and maybe even posit a question of whether that difference might translate into disease modification in other domains, right? So we've all been talking about prevention of psoriatic arthritis and other things. Is there a chance that somehow depleting more robustly these memory resident T cells might impact later outcomes like the development of psoriatic arthritis in terms of cell trafficking, et cetera? So I'd love to hear a biologist's take on that question.
Joe, thank you for those insightful comments. I agree with your observation that I think risankizumab and guselkumab are sort of similar in efficacy compared to tildrakizumab. In the clinical trials, those two did have a higher efficacy than tildrakizumab, and in clinical practice as dermatologists, we see the same thing, where those two agents do a bit better than Tildra. And if you remember in this great presentation by Gemra, those two had the higher binding affinity compared to tildrakizumab. So I think that makes a lot of sense. There is a lot of interest in the idea of remission, and can you sort of induce these long-term remissions? I think the data that Gemma presented on CD64 is really interesting, because tildrakizumab and guselkumab bind CD64 at the cellular source of IL-23 production, and perhaps maybe involved in this sort of more long-term remission. So I think, yeah, you raised great questions.
And by the way, Wilson, just to finish that thought, it's interesting clinically that we think of these as being, such similar mechanisms. I will say on the flip side that although, as you comment, the trials data suggests some similarity, we all have these patients who respond better to one than the other, or fail response to one and then respond to another. So I do think there may be something to it. I just wonder whether, is it this CD64 mechanism? Is it something else? Maybe, over time we'll get to understand that a little bit better. But
great. Thank you both for your insightful comments. Just to wrap up this discussion, I want to mention that there is a network meta-analysis from April Armstrong's group, in which they compared all these agents, and risankizumab seemed to be the one that had the highest passive response, both in the short term and long term, compared to others, including guselkumab, which had like a 10% less passive response compared to the rest. So I think that there is much more to uncover from these agents, and that head-to-head studies should be providing more evidence as we move forward. Okay, so we will move now on to the next section. So thank you again, Dr. Liao and Semra, for wonderful presentations. Now we're going to move to the clinical topics. So Dr. Mio Nakamura will be presented the abstracts that were selected for clinical topics, and she has been supervised by Dr. Priscilla Calistafin. So thank you both very much, and I'll leave it now to Mio to continue with the presentation.
Thank you. Hi, everybody. I'm really excited to be here to talk about some of the chosen clinical posters from the AAD this year. So here are our disclosures, and we'll dive right in. So we have chosen these 3 posters. And so the first one is titled, "Do Biologics for Psoriasis Prevent the Development of Psoriatic Arthritis? A Population-Based Study." So this was a study done by a group led by Dr. Armstrong, April Armstrong at USC. So as we all know, psoriasis commonly precedes the diagnosis of psoriatic arthritis, and biologics can treat both of these conditions. But literature has been mixed on whether biologics for psoriasis prevent the development of psoriatic arthritis. So the aim of this study was to examine the incidence of psoriatic arthritis among a cohort of moderate to severe psoriasis patients treated with biologics versus without a biologic. So they conducted a retrospective cohort study. They used a database called the Optum Clinformatics Data Mart, and they looked at data from 2007 to 2021, which contained 73.4 million patients. And they looked at a cohort of newly diagnosed psoriasis patients who were treated with phototherapy as first psoriasis treatment with no prior arthritis history and no prior use of biologics or oral systemic agents. And so they looked at these patients and looked at the exposure, which was treatment with a biologic, and they looked at the outcome, which was incidence of psoriatic arthritis after 10 years. Next slide. So this is the demographic characteristics of the two groups. So patients who were exposed to phototherapy only versus patients who were exposed to phototherapy and then a biologic. So there were some differences between these two groups, which is important to note. So patients who were exposed to a biologic tended to be younger at the time of psoriasis diagnosis and at the time of phototherapy initiation. They were less likely to be female. They were less likely to have comorbidities such as hypertension and diabetes. They were observed for longer, and they were more likely to have been on oral systemics for a longer duration. Next slide. So when comparing these two groups, they did find that the incidence of psoriatic arthritis is decreased in patients treated with biologics compared to phototherapy. So patients who were exposed to biologics had an incidence of 25 per 1,000 person years of psoriatic arthritis, while the phototherapy only group had a higher incidence of 50 per 1,000 person years, and this was statistically significant. And when they compared some of those demographic, baseline characteristics that were different between the two groups, they controlled for those and still found that the incidence of psoriatic arthritis was lower in patients treated with a biologic compared to phototherapy alone. Yes, next slide. This is a nice Kaplan-Meier survival curve showing the same thing. There's a significant difference in the probability of developing psoriatic arthritis in patients treated with a biologic versus phototherapy alone. So this study concluded that biologic use may reduce the development of psoriatic arthritis among psoriasis patients. One of the limitations that we noted was that there was no data available on psoriasis severity and affected locations between these two groups, and these things may affect the risk of psoriatic arthritis. So those are things that we would like to know a little more about, but overall, very interesting finding from this group. Okay, so the next poster is titled Identification of Demographic and Clinical Features Associated with Multi-Biologic Failure in the COREVITAS Psoriasis Registry. This is a study that was performed by the group at UCSF. So there are many treatments available for treatment of psoriasis, including many biologics, and factors associated with poor therapeutic response to multiple biologic agents in psoriasis are not well studied. So the aim of the study was to identify patient characteristics associated with multiple biologic failure. So this group conducted a prospective multi-center cohort study in the COREVITAS Psoriasis Registry. They performed multivariable mixed effects logistic regression analysis of sociodemographic, clinical, and patient-reported outcome measures. And they compared these factors among patients with multiple biologic failure versus patients who had a good clinical response to a biologic. So they defined these as, so multiple biologic failure was defined as, can you go back? Sorry, as patients who received 2 or more biologics of different classes, each for 90 or more days, but discontinued due to inadequate response. And good clinical response patients were defined as patients who had 24 months of continued index biologic use by last registry visit, so 24 months or greater. Okay, next slide. So this is showing the patient selection and demographic information. The group initially identified about 4,000 patients who were biologic naive psoriasis patients who initiated their first biologic agent between 2015 and 2022. They excluded patients who were followed for less than 2 years in the registry, patients who did not have a valid drug start date, and patients without valid baseline assessment data. And so they were left with about 1,000 patients with complete baseline data and more than 24 months of follow-up. And the demographic information for this group of patients, mean age of 49 years, 44% female, majority white, mean duration of psoriasis was about 12 years. About 30% has psoriatic arthritis, which is consistent with kind of the population data that we know. Mean BSA of 16%, mean PASI of about 10, and IGA of moderate or severe in about 83.1% of patients. And of these, about 1,000 patients, there were, sorry, will you go back? Okay, there were about 490 patients who had a good response and 65 patients who had multiple biologic failure. So this is a chart showing the significant differences between some of the characteristics of patients with multiple biologic failure versus good response to a biologic agent. So these are highlighted here and summarized on the next slide. So the group found that multiple biologic failure was associated with female sex, hyperlipidemia, Medicaid insurance, earlier year of biologic initiation, shorter psoriasis duration, and prior non-biologic systemic therapy. So they did not find any significant differences in terms of patient-reported outcomes like DLQI, VAS, etc. So the group concluded that these findings help stratify psoriasis patients at risk for multiple biologic failure and may identify patients who will benefit from more frequent clinical follow-up. Some of the things that I would have liked to know more about was the physician-reported outcome measures such as PASI and BSA between these two groups. The last poster is titled Characterization of Cardiometabolic Risk Awareness and Management in Patients with Psoriasis, a Pilot Quality Improvement Study. This was a study done by a group out of NYU. As we all know, psoriasis is associated with an increased risk of cardiovascular disease and cardiometabolic risk factors. Guidelines recommend that psoriasis patients should be educated on these risk factors, but it is this patient education remains under-recognized and the risk factors remain undertreated. And so the aim of this study was to assess psoriasis patients' degree and awareness of cardiometabolic risk and receptiveness to further education and risk factor mitigation. So they conducted a pilot quality improvement project on patients with psoriasis receiving topical under systemic treatment or phototherapy at NYU. And they passed out a 47-item questionnaire, which was drawn from the 2021 to 22 CDC NHANES. And they looked at demographic information and cardiometabolic medical history, screening, and risk awareness. So this is the demographic information of the survey participants. So most of them were male, mostly middle-aged to older adults, mostly non-Hispanic white patients, and a lot of them did not have history of cardiometabolic risk factors such as hypertension, dyslipidemia, diabetes, and coronary artery disease. Dyslipidemia was seen in almost 50% of patients, though. In terms of the survey answer, the questionnaire answers, so 100% of patients actually said that their blood pressure and weight were checked in the last 2 years, and their cholesterol was checked in about 80% of patients, and then less than 50% of patients had their hemoglobin A1C checked. Only 35% of patients said that cardiovascular disease risk screening was recommended by a doctor or other health professional. And then only about 27.5% of patients were aware 27.5% of patients reported they have been educated on the connection between psoriasis and cardiovascular disease. And then 82.5% of patients said that they would be receptive to further education regarding the connection between psoriasis and cardiovascular disease. So they concluded that most patients with psoriasis have not received effective counseling regarding their elevated cardiometabolic risk. And psoriasis specialty clinics and interdisciplinary clinics may provide a valuable opportunity to screen and educate patients on these risk factors, and educational initiatives to increase clinician awareness is needed. And one of the limitations of this study that we've identified is that it's a single center study, so it may not be generalizable, but it certainly does hit a good point. We can take any questions.
Yes, thank you, Mio. I think there are a lot of questions, a lot of discussion already ongoing and the question and answer. And I can only congratulate you to the abstracts that you selected and how you presented them. It's really fascinating. And I think that we will still have some time for some questions. And there was already a very heated discussion ongoing. And Guillaume was asking, from a clinical point of view, is preventing PSA is difficult to demonstrate because the drugs, the biologics that were assessed are effective in treating signs and symptoms of PSA as well? Or are we really preventing the disease outbreak, or are we only treating very early with efficacious drugs? And I think this is actually the key point of question that we are answering. I mean, for the patient itself, it will not make a dramatic difference because if he or she is feeling better with the medications, but I think it's really from the mechanistical point approach, it's really fascinating. And I saw that Christina was also wanted to share her thoughts on this. So maybe you can already jump on this, Christina.
Sure. This is a database that you don't know the decision level and phenotype level information because of the way that it was designed. So, and I just think it's really fascinating that theoretically patients who are going to do phototherapy would likely have more trunk and extremity disease and less of the, what we consider phenotypic associations with psoriatic arthritis. And yet, even after adjustment, you still see this higher risk of PSA. And I think Guillaume's question's really relevant. Are we, are physicians selecting patients for biologics because they have those phenotypic features and already some joint pain, right? So those factors may be at play, but I think this, and Joe pointed out that there's going to be more ongoing prospective data coming forward from Pampa and other studies. But I feel like it's an interesting study and a clue.
So also one question, did they assess, are there any differences between the biological agents they're using? Mio, was this okay?
No, they did not. They only looked at just any biologic agent, did not break it down.
And that would be so interesting to know, right? I also wanted to, so Mio, fabulous job, just incredible. And she did a great job. We put some limitations at the end of each of the end of each abstract. And I feel like the multiple biologic failure question is so interesting. There's a lot of work going on in the psoriatic arthritis world. And so I'm curious as to the group's feeling about multiple biologic failure. And if, I guess the question for the group is, do we have a really good feeling for this being a real thing, or is it just that we're missing something about psoriasis? Like, do they also have allergic contact dermatitis? Do they have other phenotypes? And are we not working this up adequately when patients have a failure of their biologic? So I'm just curious, especially from the arthritis standpoint, if do you feel like this is sort of a real thing? And Wilson, you're the senior author on this paper. If you feel like this is a real thing, or if we're just not clinically getting it right on our first shot.
Great question, Christina. I actually think it is a real thing. I think there are probably different flavors of psoriasis. Some of our genetic work is showing that the genetics may influence response to different therapies. So I don't think it's misdiagnosis or misclassification, but I'd love to hear the perspective from the room side.
Yeah, I think just adding from our side, I think that we are quite enviously looking at the dermatologicals because PASI 100 response, and if we would translate this to a room perspective, this is something that we don't see. And I think here again, also, we need to be aware that we are not assessing only the objective signs of arthritis, but also take the patient-reported outcomes into account, including fatigue, joint pain, and I think this is also limiting those aspects. But we do really see difficult to treat, difficult to manage PsA patients in our clinical life, and I think this is something that we need to assess better and to try to come up with a definition and also characterize those patient groups, because I think currently we are still missing something with the treatment availability.
Yeah, and Fabian, I might just say to bridge those two comments, I agree with everything that's been said. In some respects, Wilson, I think we're going to have to learn a bit more from dermatology and from psoriasis, because there is a little bit more, in theory, objectivity in seeing those multi-drug failures, being able to do skin biopsy, being able to get some biospecimens, and answer those questions. Because to Fabian's point, I think the challenge we have on the PsA side, I also believe we have true multi-biologic, drug, even combination failures for sure, and there, the best data I have are the patients who still have tender swollen joints that I can physically see, touch, etc. But we have this huge world of folks who have continued pain, despite, as far as I can tell, pretty quiet joints, even sometimes on imaging, completely quiet joints. And yet, they wouldn't meet our metrics for low disease activity. And so I think it becomes even more challenging in PsA. So.
Wonderful, Joe. That was a wonderful comment and a great discussion. Thank you, Dr. Liao, and for the comments, and a special thank you to Mia and Christina for the wonderful presentations on the clinical topics. In the interest of time, we're going to move into our last session for today, which is focused on psoriatic disease treatment. So for this session, we will have Betul Turk and presenting the slides, and she has been supervised by Dr. Merola. So Betul, the floor is all yours.
Hello, everyone. My name is Betul Majid. I'm a clinical research fellow at Brown Dermatology under the supervision of my dear mentor, Dr. Abbvie. So today I'll be covering treatment part of the Congress highlights. So we choose 3 posters from the Congress with my supervisor, Dr. Merola. So I would like to thank him for his guidance. Previous slide was our disclosure. So first abstract will be about the impact of risankizumab on nail psoriasis and enthesitis in patients with psoriatic arthritis. Next, please. So the aim of this study to assess the efficacy of continuous risankizumab treatment on nail psoriasis and enthesitis for patients with high nail psoriasis symptom burden. So they used data from the KEEPS-A1 study, and patients with active psoriatic arthritis and plaque or nail psoriasis were enrolled in this study without any history of prior biologic treatment. There were 2 periods in this study. First period was they randomized patients to receive risankizumab or the placebo, and period 2, patients who received placebo were switched to risankizumab. And all patients received risankizumab of every 12 weeks from week 28. So inclusion criteria of this study was the patient with a physician global assessment of fingernail psoriasis score 3 or 4, and they used modified NAPSI, PJF, and the lead enthesitis index as outcome measurements. So here we see the response. The green line represent the continuous treatment of risankizumab, and you can see patients show 74% improvement in their MNAPS score. And in the right side, we see the 61% improvement in their PGF score. But on the other hand, patients who are switching from placebo to risankizumab at week 24 demonstrated 57% of improvement in their MNAPS score, and then 53% improvement in their PGF score at week 52. Next slide. And as I told you before, the inclusion criteria of this study was the high score of PGAF. So despite the high baseline level of nail psoriasis in this study, patients treated with continuous risankizumab demonstrated improvement in their signs and symptoms of nail psoriasis. In this graphic, we see after 52 weeks of continuous risankizumab treatment, the majority, like the 60% of the patient, achieved clear or minimal nail improvements in their PGF score. And the total nail clearance, which means the modified NAPS0, was achieved by 30% of patients receiving the continuous risankizumab treatment. And 69% of patients achieved resolution of enthesitis after the continuous treatment of risankizumab. So why we would like to discuss this abstract here today? Because nail psoriasis, as we all know, is strongly associated with the psoriatic arthritis. And the current studies have shown that those patients with nail disease has high probability of having the systemic enthesitis. So it's really important for the dermatologists and rheumatologists to accurately diagnose and treat nail psoriasis to delay the onset or the progression of the joint disease. And also, improvements in nail psoriasis may take longer to observe compared with the skin because of the slow growth of nail. That means that longer follow-up period needed in the clinical trials to adequately evaluate for us to treatment response for the nail psoriasis. Next, please, and then next, please. So they use a couple of they are outcome measurements that we use in our clinical trials, like the modified NAPS-PGF, but it's hard to evaluate how much improvement as a percentage in those scores. So it's I think it's more practical to use the complete resolution instead of the percent in improvement. So that was all for this abstract. So we'll be continuing with the bimekizumab in patients with psoriatic arthritis and skin involvement. Next, please. So they assessed the radiographic progression in patients with psoriatic arthritis treated with bimekizumab compared with the placebo in this study. And they also assessed the impact of baseline psoriasis severity on the efficacy of bimekizumab as measured by radiographic progression. So they use data, next please. They use data from the BOptimal study, which is which study comprised the 16-week double-blind placebo-controlled phase with 36-week active treatment blind phase. So they measure radiographic progression based on the Van der Heijden total sharp score, and they reported here to week 16 by the extent of baseline psoriasis. Next, please. So in here, we see the cumulative probability plot of radiographic progression demonstrated that patients with placebo group had a greater degree of radiographic progression when we compare with the bimekizumab group. Next, please. And here we see the change from baseline in their score by body surface area subgroup. And the bimekizumab group show greater inhibition of radiographic progression than placebo group. And it's regardless of their body surface area, as we can see in here. Next, please. And the percentage of patients with no radiographic progression at week 16 was higher for the bimekizumab treated patient when we compare with the placebo group, again, regardless of baseline psoriasis. But in here, we can see that majority of patients, from the percentage that we can see, majority of patients did not have radiographic progression. So all the data in this study based on a small number of progressors. Next, please. So in here, we see at week 16, joint narrowing subscore was lower in bimekizumab group when we compare with the placebo group. And we also can say that larger improvements seen for the joint space narrowing in those in the higher body surface area when we compare with the lower body surface area group. So again, in here at week 16, we see erosion subscore were lower in bimekizumab treated patient compared with the placebo. And also in this graphic, we can say that placebo group showed that more body surface involvement seems to be linked to greater radiography progression. So that was the end of this abstract. I'll be mentioned. Next, please. So our last abstract is about new tyrosine kinase 2 inhibitor, oral medication for a patient with moderate to severe psoriasis. Next, please. So this is a phase 2b trial, was designed to assess the efficacy, safety, and tolerability of this drug in patients with moderate to severe psoriasis. And this is a selective oral allosteric inhibitor of tyrosine kinase. Next, please. And this is a randomized double-blind placebo-controlled study, and the study evaluated 4 dosage of drug taken orally once per day. They randomized patients based on their dosage, including the 2 milligram, 5 milligram, 15, and 30 milligram versus placebo. And the primary endpoint of this study was the PASI 75 at week 12. So here we can see the results. The primary endpoint, as I told you, was the PASI 75 response, and 68% of the patients who were on 15 milligram achieved PASI 75 versus the 0 in the placebo group. And the secondary endpoint was the PASI 90 response, which achieved 45% of the patients who were on 15 milligram versus 0 in the placebo group. Next, please. And the adverse event rates appear to be similar across the arms, as we can see in here. So I would like to represent this abstract as this is an alternative oral tyrosine kinase 2 inhibitor. It seems like the similar efficacy and safety profile in the phase 2 study. This was the end of my conversation. I would like to thank each one of you for your patience, and I'm happy to answer if you have any questions.
Wonderful. Thank you so much, Dr. Masit and Dr. Merola, for this wonderful presentation. So we're running a little bit late with time, so I think we will jump into what's the panel discussion, and we can definitely discuss the last presentations mostly. But before that, I would like to introduce our patient research partner who was very kind to join us today, who is John Latella, and the hope was for him to make any comment or question if he wanted in the during this panel session. So John, hi. Do you have any comment or question about the abstracts or presentations that were presented today?
Well, I have just a few things they're personal to me. I was diagnosed with Parkinson's, and I've been looking at data on that, and there's not a lot of data that I can say that they're connected. Some clinical studies say yes. So do we limit to the diseases we know that are caused by psoriasis or affected by psoriasis, or can we expand it a little bit? I understood the first two. The last one I was a little bit lost. I'm not a technician or a researcher. I think they were both all well presented. And I did do phototherapy in the past, but it happened to be PUVA. It was not narrowband B. It hurt me more than helped me. I've been on a biologic since 2005, and it is the only thing that keeps me sane and safe.
Wonderful. Thank you for your comment, John. With
maybe
that,
I can also ask one question to Joe and also Betul regarding the bimekizumab data that was presented, because this was the 16-week data, and I think that at least from my perspective, this is rather a slow process of the radiographic progression. Do you think that the results will change when we have a longer follow-up? Because I know that the 52-week data will be presented at EULAR, and I think 16-week is rather short. I mean, we see already a small difference, but do you think that this difference will increase over time?
It's a great question, Fabian. I'm happy to take a first step. I think that, one of the things I think is amazing is that we even see a difference in the placebo group in that short time, right? To your point, I mean, we don't think about a lot of people progressing, and yet we're able to see some change there and see some change, granted, I think it's important, and this is why it's nice to have these conversations in a mixed, audience of derm and rheum, we forget also that these studies for the dermatologists, these studies are enriched for progressors, right? These are folks who have baseline erosion, they have elevated inflammatory markers, they have reasons to be progressing, to be having erosion, or at least at an accelerated rate. So it's not reflective necessarily of our general patient coming into clinic necessarily. But Fabian brings up a really amazing point, which is, we see some progression over that time. I would expect, to your point, Fabian, that those, yes, that that these trends would continue, maybe be even more dramatic over the course of 52 weeks. What's also interesting, those are not truly placebo patients. We think of them as placebo patients, but most of those patients are on background concurrent DMARD. So it also is saying that people are progressing over that time, not only in the short time, but through background baseline DMARD therapy, mostly methotrexate and such, in 60–70% of patients or more. So I always find these interesting. It's also interesting in that you can see a comparator group that we have both TNF inhibition and IL-17 inhibition in that study. That's interesting as well, right? And there may even be some, was not looked at statistically, but if you really dig under the ground there, there may even be some difference numerically between what you see with TNF and what you see with even robust IL-17 there. So I think there's a lot to be unpacked. I wonder, Fabian, what your interpretation was as well, because it's a good question.
No, this was exactly because I was surprised that we already see a difference after this short amount of time, and I would be cautious with making conclusion of superiority of IL-17 ANF inhibition over TNF on this short amount of time, and also on the patient numbers. But I think this is something that we can really much look forward to see longer term data, and then also hopefully real head-to-head data.
So let me ask you something from someone who likes outcome measures. I have no idea how you measure this radiographic progression, right? So I was thinking, is it a standardized tool and metric that you're using across all these different clinical trials that you are discussing, right?
Okay. It is. Yeah,
it is.
Because it has to be very granular to be able to capture this level of progression in such a short period of time, I would imagine. So
this is absolutely true. Just but we also have to say that there are some limitations to this method, because if you ever have done this, there's some failure rate to this. But I think still over the numbers that will limit itself. So I think this was a great question, and think that the longer term data will need to be shown to really show that this is a true difference measured and not used to the limitation of the method itself.
Awesome, thank you. Any other questions about these latest presentations from the panelists or from the audience? The attendees, or even if you want to bring up a question from the previous presentations, this would be the opportunity.
I would love to ask a question and also maybe include John into this, because I think this was about the cardiovascular risk screening study. And I think this is really one of the burning questions that I'm asking myself every day in my clinic, because I only have a short amount of time seeing my patient. And I think that especially the cardiovascular risk is something that we should focus much more on. And even though I'm not only a rheumatologist, but also an internal medicine specialist, I don't have the time to check in all my patients, all the cardiovascular risk scores that I would like to. And so if you have, and I know that there's also from the group from Toronto, there's a combined room cardio clinic. And I think, how are you guys handling this in your clinical routine? And maybe also towards John, how is this in your experience? Have you ever been advised to seek screening for cardiovascular risk factors?
If I go first, yes, I have. Matter of fact, I've had open heart surgery where I had two double bypass and a aortic replacement. And I'm watched constantly because the aortic valve tends to have growth on it. And I see a cardiologist at least 4 times a year. And it's physicals at least 3 times a year. I'm constantly watched in those 2 things. I've been doing very well, so I have not had any problem with any kind of cardiac problems since then.
Fabian.
Yes.
And Lourdes, by the way, I just want to say before we end, thank you for your excellent facilitation today and for everybody else's excellent comments and participation. I just wanted, and I'm not an investigator on the study, so there's no conflict of interest. There is a study that's being launched soon, sponsored by the Psoriasis Foundation, National Psoriasis Foundation, called CP3, where they're exploring this idea of taking the screening activities out of the clinic and centralizing it. So randomize, having patients who are eligible, who don't already have heart disease, to screen them, but do it centrally with an online coordinator and determine if this intervention is effective, because we all have so many busy things to do. John, you probably know that, don't always have time to address every single question with your doctor. And I think that's going to be the way that we do it, is to take that out of the specialist's hands and do it more centrally. So anyway, I hope that is what can happen, so that we have a higher, and shout out to NYU doing it well, right? They got 100% on their hypertension screening. That's amazing, but not generalizable, I don't think.
Wonderful. Thank you so much, Christina, for that comment. I think that we are over time, so we should be wrapping up. So I wanna take this opportunity to truly thank Dr. Turk, Nakamura, Masid, and their supervisors, Dr. Liao, Kali Staffin, and Dr. Merola, for the tremendous work that you put to get this together for today. I know that you all have very busy schedules and lots of responsibilities, so we truly appreciate that. We also want to thank Fabian and I, GRAPPA administration, especially Annie Spangler, who has been truly instrumental in getting all of this together and doing all the social media advertising. Thank you, Annie, a lot. And well, of course, my co-host, Fabian. This is the second time we do this, and it has been a pleasure to bear with you, and to all the attendees for being here today to support this initiative and your interest in psoriatic disease. We wish you a wonderful day and rest of the week and weekend.
Maybe I can only add, because we are already really much looking into the future when we are going to discuss the highlights that are going to be presented at the AAD Congress that is taking place in June in Milan. And there we will focus again on the rheumatological perspective and the new highlights on psoriatic disease. And I'm really much looking forward to see many of you there. And it was a real pleasure. Thank you, Lourdes. Thanks to all participants, and thanks to the audience for your interest. It was a real pleasure, and have a great day.
And please complete the feedback form when we send it, because it will be really helpful to improve the session for the next time. So we are open to your comments. Bye-bye.